Hi everyone, and welcome to this podcast episode of the International Journal of Dermatology. I'm Lajos Kemény, the editor-in-chief of the International Journal of Dermatology, and our special guest today is Dr. Eduardo Nagore from Spain. But first, let me introduce to you Professor Nagore. He is a section editor of the melanoma unit of the Oncology Institute, Valencia, Spain, and a professor at the Catholic University of Valencia. He has been working in the field of skin cancer for 25 years with a particular focus on Mohs surgery and melanoma, which has been the main subject of his research. He is an active member of several international consortia, including Genomel, Intermel, and Melanostrum. He is also a board member of the EADO and the Spanish Academy of Dermatology. He has previously served as a board member of the EADV. He has authored more than 300 articles indexed in the PubMed. So, hello, Edu. I'm very pleased that you could join to us today.
Pleased to be here as well. Oh, very nice. Okay.
First of all, I would like to thank you very much for your hard work that you are working for the journal as a section editor of skin cancer. Could you tell us a few words about your motivation? Why did you accept my invitation to join to the board? And how do you feel yourself in this position?
Okay, first of all, obviously, because I knew you. I mean, I like the way you work, the way you're doing things, and I also like the idea you got. I mean, to improve, to make the journal a better journal, to place it at the top. So it was a kind of a deal, a nice deal. And then, since you think about focusing on people that are actually involved in the pathology, so that's my field, and I feel comfortable helping in this regard. I mean, so it is relatively easy to assess if a paper, if a manuscript is nice, so that we can keep a nice information to be provided to our readers. So yes, and I do like it. Many years reviewing papers, you learn a lot from papers, from the worst or from the best ones. So yeah, it was a nice deal, and also nice to join the very nice team you have put together.
Yeah, and what do you think? What is the most difficult thing in your position? We introduced the junior editor position at the journal, and I know that you have also a junior editor, Dr. Moro. How do you feel this? Is it really a good idea? And what is your opinion on that?
The idea is wonderful, because usually when you choose something to be section editor, you try to look someone with time. I mean, with experience, and many times, like it happens with you for sure, we are busy with many issues, projects, patients, responsibilities at the department, and so. And therefore, okay, this is an extra time usually you do at home in your free time. And so having a young people who is enthusiastic, who wants to be, who wants to follow this kind of career, is very helpful. And mainly if you have, let's say, face-to-face. So in this case, Dr. Moro is working also in melanoma in my department, and it is close to me. I mean, it's in the next room, so we can work together. So the idea is perfect, because they kind of filter. They kind of doing a filter, just trying to give you an overview, so reduce the time you might need. It is true that technically the journal should manage a little bit more this to help us to do it in a proper way, but the idea is very nice for both, for me and also for the young people, to give the opportunity. Otherwise, we are becoming older and older, so we are always occupying all this sign, we will never have young people who can reach this level. So that's perfect.
Yeah, with time they can replace us definitely, and this is also our initiative. The goal of this initiative to teach the younger generation how to become an editor or a section editor of a journal, because this is really sometimes extremely difficult, especially when we are talking about finding reviewers. Finding a reviewer is more and more difficult nowadays because it is not reimbursed. But in the whole publishing industry, this is the most critical aspect, because we doctors are very busy and we are working in many different fields. We are involved in patient care, administrative tasks, and so on and so on. And then to review papers is just for free. This is really not usually not very easy. But on the other hand, to go further in our academic career, we have to have papers published, and we do need reviewers. And sometimes we have authors who are asking us why we did not do the reviews in time. On the other hand, when we invite the same authors to review a paper, they will say, okay, I'm sorry, I don't have time. So this is difficult, but the journal editors could help us finding reviewers who are willing to work for the journal. So we have just returned from the EADV Congress. That was the biggest ever EADV meeting so far. What was your opinion about this meeting, and in which area in dermatology have seen the most exciting developments? What is your feeling on that? You have been involved in many different sessions, and you can share with us your thoughts.
Absolutely. So I must say, for many, many years ago, we have been evolving this meeting, the EADV meeting. And in the very past, I remember when I was a resident, the best congress was the American Academy of Dermatology. That was the best one. And in my opinion, right now, the best one is the EADV Congress. I mean, right now is particularly for us, for the people living in Europe, in which it is much more comfortable to travel. It's a much easier way. And the content has improved in such a way that it is giving an update in almost everything. So the committee, that is the programming committee, SPC, I mean, you know, I was part of it, and I'm aware of the huge work they are doing to find not only senior speakers, but also people, young speakers, or the rising star they are calling, trying to look for people that are really involved. So right now, for example, choosing speakers, they are checking publications, checking if actually people is working on the field. Therefore, the information that is provided in the Congress in overall speaking is very nice. Overall speaking, obviously there might be some ones that are not. And in this term, obviously the sessions I'm interested in they are the ones about melanoma. So there were nice discussions about a hot topic right now, for example, about sentinel lymph node biopsy.
Yeah. Could you tell us about this session? Because I know that you had a lecture about sentinel lymph node biopsy, and there was another session asking whether do we need still, there's a controversial section, do we need still lymph node biopsy or not? So could you share with us
Absolutely.
your thoughts?
Yeah, it was a pretty good discussion on that. Firstly, because it was just, okay, I have the opportunity of give my opinion. I give the lecture based obviously on...
Please share with us your opinion, please.
Yeah, okay. and also, I will also put together my opinion with the opinion of the controversy, because the two speakers that were involved in the controversy were very nice ones. You know, it was Monica Arepenbagarova from Prague and David Moreno. They have the role. You have to play the role to be against and in favor. But finally, the thing is, I think we cannot get rid of sentinel lymph node biopsy yet. it still provides information, in particular to those early melanomas. I mean, meaning the 1B and the 2A mainly. And in terms of the 2B and 2C, that right now, they are going to receive immunotherapy regardless of the result. They can also provide information in terms of prognosis. And also they have a slight, let's say a small role in the therapy, not in terms of melanoma specific, not in terms of overall survival, because the history of the overall survival is related to the hematogenous dissemination and not the lymphatic. But sometimes if you perform sentinel lymph node biopsy and you remove and it is positive, only 20% or around this percentage, depending on the stage, is going to have additional lymph nodes. So sometimes removing just the lymph node, that's the only disease, additional disease that the patient is going to have. So it has a small therapeutic effect. And right now with this trend of the neoadjuvant, the trend and trials on that is even to give adjuvant therapy, immunotherapy before the sentinel lymph node biopsy. In ASCO, it was presented something about that.
Yeah, or even before removal of the primary tumor.
That would be wonderful. You know, that is something we would like to do. Right now, unfortunately, we do not have let's say, a precise way to stage the patient before and to know the characteristics that right now, even though the appearance of these molecular platforms, diagnostic melagenics and immunoprint and so on, even though they exist, they are not so good as to get rid of the classical pathological, like mitosis, like vascular invasion, regression, and so. So we need still for this purpose, that's something I would love to do, something that give us this information before doing that. But of course, I entirely agree with you.
Yeah, there are some genetic tests to predict the prognosis of melanoma. Could you share with us a few thoughts on that? About this, there are many different ones. What is your opinion? Do you do that regularly or just in special cases?
No, we regularly do only a panel, an NGS panel, not any of the commercial ones, so that we classify, and we use BRAF, and we use NRAS, and we use TET promoter mutations. You know, I have been working on TET promoter mutations many times, and sometimes, depending on the results, I modify a little bit the follow-up, meaning that even if you have a 2A or 1B, that usually you are going to have a soft follow-up. If they have, let's say, for example, NRAS and TET promoter mutation, so I follow up in a more intensive way. And regarding all these commercial genetic tests, okay, they could be useful, but they have mainly good negative predictive value, meaning that could perhaps avoid doing sentinel node biopsy. We are not doing, they are too expensive, and unfortunately they are not included in the guidelines because they have not been prospectively validated. I'm aware that some of them are in this regard in the process. And until we have this kind of data, I think we cannot have this as a regular tool, as a normal tool to use in the routine clinical practice.
Yeah, I see. Thank you. In this session, the controversy session, there was another topic that was touched by Giuseppe Argenziano. Whether do we have overdiagnosis in melanoma or not? What was your opinion on that session, on that part of the session?
It was a beautiful session as well.
Do we have overdiagnosis or not?
That's clear. I mean, that's clear. And it was very nice because, you know, they offer two views. I mean, the two different concepts of overdiagnosis. Overdiagnosis might be regarded or might be considered as a failure. I mean, when you see a typical nevi, a dysplastic nevi histologically, it is too too bad, and so okay, you prefer to say that it's a melanoma, whereas you are not convinced. This is overdiagnosis, meaning actually it is not a melanoma, and you are calling it a melanoma. But the real concept that is concerning right now, and it was also raised recently, has been talked many times by David Elder, who is part of the WHO or classification system, a well-recognized pathologist. He talked about overdiagnosis is when we are removing and we are treating melanoma that really they are harmless. So this diagnosis of this melanoma, we see the survival curves, we see there are a lot of them that never develop metastases. Mm-hmm. So we need the other way around. I mean, we need something molecularly, histologically, whatever, that say this is a harmless melanoma. And perhaps we could call in another way. I mean, it happens also with the prostate cancer. And it was very nice. I didn't know. Emilio Zala raised the point that in 2002, the concept of overdiagnosis was proposed based on the prostate cancer, meaning that there are many cancers that are harmless. I mean, so this is a very nice thing because finally, for example, we might consider, we might modify our guidelines, for example, for in situ melanoma, remembering even with Ackerman, when they say, okay, just remove the lesion with free margin, that's enough. So perhaps for this in situ melanoma with some characteristics, we can just treat it in a lesser aggressive way with lower margins or lower or soft follow-up.
Yeah, because the patients are shocked if they receive the diagnosis of melanoma, and their quality of life later on will be severely damaged because of having this diagnosis. Could be a little bit simple.
Yeah. And also, sorry to interrupt, and there's also a legal thing. I guess you have to deal with patients like that, in which you are given a diagnosis of melanoma, and then if they have a life insurance, sometimes they don't want to give the insurance. I mean, they don't have, because they have had a melanoma. So this is a very important thing.
Yeah, this is an interesting aspect. I was not thinking on that. But actually, there's another situation when we are talking about skin cancer, the actinic keratosis. Is it skin cancer, keratinocyte carcinoma? In the US, in Europe, we used to call these lesions actinic keratosis. This is probably not as shocking for the patients as keratinocyte carcinoma. But anyway, this is just nomenclature, how we call a lesion that is actually not really dangerous. So, and tell me, what is your current research topic? You are working on that.
Okay, always what I like is to have a hypothesis for the clinical, and with clinical modification that might help. For example, we have performed a couple of studies focused on those melanomas that appeared on without a primary. I mean, meaning sometimes you detect a melanoma with a nodule, and you don't know if it's a dermal melanoma, which has been called dermal melanoma, or perhaps it has been a metastasis from a primary that has disappeared, maybe because of complete regression. And it also happens with the lymph nodes. Sometimes you detect lymph nodes and metastatic lymph node with no primary. So we have analyzed that, and we have shown that they behave in both situations better, meaning we don't know if it is because there was it was a primary and a good immune response, or perhaps it is a primary that appears even in the lymph node. For example, we do know that there are nevi, melanocytic nevi in the lymph node, and it could be a primary. So there's something there quite new. And we are about also to work on nutrition. I mean, we would like to see, you do know that the fiber intake and how nutrition modify the immune response and modify the quality of life. So it's something we are starting. And the third thing I would perhaps like to share is you also know by you have been involved in Euromelanoma and the campaigns, prevention campaigns, and so on. And the thing is, we have been given the information that the most important thing is to avoid sun exposure, and so that's nice. That's cool. There's no problem with that. But the fact is, when at the clinic, we see many cases, apart from acral lentiginous melanomas, that appear in people that have not had sunburns, they don't have nevi. So we are missing a group of population that are at risk and they don't know they are at risk because we are providing information which are the risk factors. Okay, nevi, fair skin, sunburns, whatever. But anyone can develop a melanoma. And in this regard, in the setting of melanostrum, we collected samples. It is unpublished papers we have developed, and perhaps one of them I will send to our journal to share and to perhaps to start with the idea. And the proportion is not that low. In my experience, perhaps 20-30% of non-acral melanomas does not have common risk factors sporadic, out of the familial melanoma. So there's something important so that we can give the population the recommendation of self-skin examination in a monthly basis to detect any melanoma, and particularly, as you know, the nodular one, the fast-growing melanomas that cannot be detected even if you are going regularly to your dermatologist.
Yeah, the screening and the evaluation, the skin, whether do we have a new lesion is really critical. We have had a clinical trial in Hungary. It is not published yet, with I guess close to 20,000 children, kids, and even 7 years old kids could evaluate lesions that, of course, not as a cancer or melanoma, but just, I guess, that should be investigated by the doctor. 80% of these younger kids were able to identify lesions. With them, they have to go to the doctor. That is crazy. And the patients usually came late. The critical question is, whom to scan, because the screening and population level is not possible, of course. But then self-examination is probably the best way, as you mentioned. But then how to teach the population, and what is the best way to teach which lesion looks suspicious or not. That could be a critical issue.
Yeah, so, there are some apps that could be helpful, particularly if you add clinical information, because the app it's I think they don't have the sensitivity high enough so that they can be useful, because if we want to screen, we want 100% of sensitivity, and obviously we want to raise the specificity.
The problem is with these apps that they identify many suspicious lesions that are not suspicious at all. Unnecessary removal of normal moles is critical, and I think that this is a huge drawback of that kind of screening tools, especially if you have been screened by an AI-supported tool that would say that this lesion is suspicious. This opinion will influence the opinion of the medical doctor. And even the medical doctor, with this kind of information, will be more prone to suggest removal of an otherwise completely normal nevus. So, Edu, could you tell us what you would suggest for young dermatologists? Why to be involved in research? Why to be involved in reviewing papers? And what is your suggestion how to become a better dermatologist?
That's a very, very good question. We do have, we because I think the feeling we have is we are a little bit worried about the new generations, meaning that perhaps they are more interested in aesthetics, in money, and so. But the fact is what makes us as a dermatologist different from other specialists that are involved in aesthetics and so is that we are good dermatologists. And to be a good dermatologist, you should study a lot dermatology. And it's reviewing, writing papers makes you more critical about the results. Sometimes you can feel, you can read a paper that is suggesting a treatment, but if you have skills evaluating, you have skills because you have done research, you are more critical about the data that are presented in front of you, and you can detect things that are great. We should be more cautious about these results, but because the methods are not strong enough to demonstrate. So I encourage a lot people to be involved in research, to be people involved in reviewing, reading papers. Apart from being focused on earning money, that's okay. It is something, this is normal. But to be good, I mean, to be a good dermatologist, and it makes you better if you read, if you write papers, because you do realize which are the defects or the biases and the draws you may have in some studies. So yes, I would encourage a lot people to do so.
So thank you very much, Edu, for joining us to this podcast episode, and see you somewhere else soon in one of the DER meetings somewhere in the world. Thank you very much again.
Thanks to you.
Thank you.